My full name is Ajay or Sandhu, and my professional address is Belmont Medical Center, 18 Western Road, Southall, UB2 5DU.
Are you a GP?
I am a principal general practitioner in the practice.
Now, in front of you, you should see the submission that you put in, and it's at volume 2, starting at page 757.
I've got it in front of me. Yeah.
Can you confirm that it's true to the best of your knowledge and belief, and that you wish it to stand as your evidence for the Commission?
It is so, yes.
Now, I wanted to ask you, you are a GP and you've practiced both in Ealing and Chiswick.
I have, yes.
So does that give you an overview of two very different communities?
It indeed has.
And at the Belmont Centre, you say that's seen as a model of good practice. Can you help us with the advisory work that you've done flowing from that?
I used to work in Chiswick, and I happened to do a locum session in Southall because my colleague was desperate. And when I saw the care there, I was very touched, and I said, I'm working in such an affluent community, but my need is greater here than in Chiswick. So I gradually transformed and voluntarily gave up my Chiswick practice, and I started working in Southall. It was a very uphill struggle at the time, but over the time we did conquer, and we have now achieved the best practice status.
And I think you said that there was some advisory work you did. Could you help us with what that was?
Pardon?
Advisory work to other GP practices?
It was an example which I set in the area, because when the cough came into existence, my achievements were higher than the cough, and that's how they labeled me as the best practice, because the cough was brought in to improve the standard quality of care. But my quality of care was higher than what they have targeted.
Now, you set out in your submission that you were a founder of something called SHIP, the Southall Health Improvement Partnership.
That's correct.
Can you help explain to us, why was there a need for such an organisation when health improvement is part of the function of the NHS and the local authority?
Well, if the local authority's function was optimally conducted, there would have been no need for SHIP. When I worked in Southall, after tackling the practice population, which was about 3,500, and I achieved what I wanted to with the screening and blood tests and whatever, I felt a bit unhappy that, what's happening to the rest of the community and how can I conduct it? And I was invited to some meetings, which I pleaded to the public health directors, do something about it. Our people are dying very young, and they are dying very young, 30 years they are gone, leaving young families and young children. And the answer given to me was not very pleasant. I was told then by a top person, that's how they suffer, that's how they die, and we can do nothing about it. That was unacceptable to me. So I was very frustrated. Then I appealed to another person, medical. I said, look, you are doing your screening at 35. Our people are dying at 35. Can't we do something earlier? And he said, no, we can't do anything earlier. I was very, very frustrated. Out of frustration, I started visiting the local religious organization one after another during my free time, and I conducted these sessions. This is 23 years ago I'm talking about, and gradually I found the satisfaction when people benefited. We diagnosed people who have got diabetes, which was never known before, and many other things were diagnosed, and education was given, which we have ever since conducted, and we are very happy that we are doing that. The satisfaction is there, and the service to humanity is there.
And is it still an organisation for which there is a need?
Pardon?
Is the organisation still needed? Is SHIP still needed?
Oh, it's very much needed, because when you look at the population in Southall, having worked in Chiswick, there is such a vast difference in the two communities. The prevalence of certain diseases like, for example, obesity, diabetes, and related other diseases, hypertension, stroke, is so very high, and it is so frustrating that you can't stop doing what you are doing. And we are trying to build on that. We started with the health promotion sessions, we then went to the diabetes risk assessment, and now we are going into educating them with a dietitian, because diet plays a very big role. Lifestyle intervention is a very, very big role, which is almost non-existent in Southall.
So is that organisation carrying out preventative?
Very much preventative. I've done screening in my practice. I didn't wait for the authority to tell me, you do this and we'll pay you that. I couldn't care less for that, because I wanted my patients to be healthy. I have screened my patients for the last 15 years. which was a lot of workload, but the satisfaction was there that all my patients are screened. We do annual health checks, we do registration health checks, we do regular blood tests. Like my son said to me, Mom, he's a general practitioner in my practice now, he said, Mom, what you started 20 years ago, now the government is making it mandatory.
If SHIP didn't exist, would there be a gap in the service?
Beg your pardon?
If SHIP didn't exist, would there be a gap in the service?
The gap has always been there and will always be there because the workload is so big. What we are doing is just the tip of the iceberg. We are doing it from religious organizations. From one temple, we have gone to all the religious organizations. We go to the church, we go to the mosque, we go to the mandir, we go to the community health centers, and wherever we can catch people and give them education. And this is ongoing because the problem is so big. If anybody steps in to do the service, I'll only be too happy, and I'm always happy. I say, the workload is so great, that's never ending.
Now, I want to ask you a bit about Ealing Hospital. Now, you say that you conducted something called a practice staff inquiry about the closure of Ealing Hospital. Can you help us with who you asked and what did you ask?
Can you repeat the question, Edanda?
In your submission, what you say is this: I have conducted a practice staff inquiry. This is about Ealing Hospital. Now I come to the main query about Ealing Hospital's proposed closure. I've conducted a practice staff inquiry into this question. Can you just explain a little bit more about that, please?
Right. We had a practice of over nearly 6,500 patients, and we got a very good practice staff. And when I was to answer this inquiry, I thought I should ask everybody what their views are. So I went to the clinical staff, and they told me their views. Then I went to the non-clinical staff, that is admin side, and I got their views. Then I conducted the patients who were sitting in the sitting room, and I talked to them. And over the period, I have asked this, because the topic about Ealing Hospital is not yesterday, it has been there for a while, and I have had conversations with the community members as well, because SHIP deals with the community leaders, and I attend a lot of community forums, and there has always been this topic about, what shortage there will be, or what drastic, devastating effect Ealing Hospital closure will be. And I conducted everybody, so the view which I have put in here is not my view, it is a view of a lot of people there, and it is true.
I wanted to ask you about access. First of all, can you tell us, in your view, who uses Ealing Hospital?
The whole of the local community from Ealing are using the services. We have had a general GP meeting in the beginning when all the GPs attended the meeting and discussed the closure of the Ealing Hospital, and everybody had their hands up and said no, Ealing Hospital should not close, except 2 GPs who were the lead members in the Northwest London team, and everybody said Ealing Hospital should not close. But later on, they again conducted an electronic voting system, which was not fair, because when any elections take place, you don't reconduct it if you lose it.
Can you help us with when that first meeting was that you went to? Just roughly.
I think it was in the beginning when they were talking about the Ealing Hospital to close. We had the primary care physicians were there, the secondary care physicians were there, and there was a voting system. Suddenly asked, put your hands up if you don't want Ealing Hospital to close. And there were only 2 doctors, which I wouldn't like to name now unless you want them to be named. And
matter for you if you wish to.
So, and then they reconducted electronically. Why? What was the need for the electronic? When you lose general elections or you win, you don't reconduct them. The first one was the right one. The second one was the wrong one.
Now, just thinking about the population that uses Ealing Hospital, how difficult would it be for that local population if they weren't able to go to that hospital?
The local population is very diverse. There are a lot of capability and capacity in linguistic areas, in emotional areas, psychological, cultural, and even to go to Ealing Hospital has been an effort for them, but they are used to it, because I see patients in my consultation. Most of the time I conduct my consultations in their preferred language, and they are so interdependent on the family, and now unfortunately the families are moving out, because they are very highly qualified people. Their children, which is very interesting, they work so hard to give them the very high quality education. The children, like I met a patient 2 days ago, he said, my grandson is studying a PhD in Oxford. And we have had some articles written down as well, because the Ealing Southall population have got a future generation which have achieved extremely well. Now, they are left on their own, and they haven't got the means of traveling. They haven't got the linguistic advantage of choosing one bus and another bus, and they find it easier to get to this particular bus stop and to get there and go into Ealing Hospital. That advantage will be lost, and they will be hithered and dithered without being able to go to a faraway hospital where they will have the option of choosing 2 or 3 buses. They will not choose the 2 or 3 buses, and it will be difficult for them to do so due to their setup.
But why is it, do you say, that other hospitals, say for example Northwick Park, wouldn't be able to adapt and provide a service which has similar capabilities in terms of linguistic need? Why can't other places do it?
Well, having a hospital nearby has got a big advantage. Why would one choose to go to another hospital when you got the advantage of a nearby hospital which has served you so well and in different dimensions, culturally, time-wise, life-saving means? And why would one have, choose the option of going to a faraway hospital when they haven't got the capacity even to go to Ealing Hospital? They are now trained, they are being trained. You get on this bus stop and at the other end you'll be in the compound of the Ealing Hospital. They will lose all that. We are talking about the why can't the Northwick Park Hospital serve? We had a forum meeting recently where all the communities were there, and what many people pointed out, you talk about Northwick Hospital having the capacity. I have seen people waiting in the corridors. They don't even have proper seating arrangement to sit down and wait for it. Then I recently had one of the family members who's pregnant and she's doing PhD, and she said to me, they haven't got the capacity. I said, why? She said, I am pregnant. I had gone for a blood test, and I was supposed to have a fasting blood test in the morning. My fasting blood test when I'm 28 weeks pregnant came down at 1:30. Now, that is not called efficiency of any other hospital.
Now, one of the other things you say is that Ealing had the highest emergency attendees at A&E nationally a few years ago.
Yeah.
Do you know if that's still the case, or has that changed?
I don't think it has changed, because when I attended this particular meeting, I was invited by the Department of Health where a lot of statistics were discussed, and I was very surprised and sad to know that Ealing Hospital has got the highest emergency attendance because of the kind of care setup they have in the community. And of course it is justified that, or we can understandable, because we have the highest prevalence of diabetes, obesity, heart attack, stroke. Nationally they are the highest. And if they're highest, of course the emergency is going to be high. Then culturally also, people are not smart like the patients I had in Chiswick, where they knew something is going to go wrong. They come to us early. Here people don't come early. They come at the last minute when they've got the problem, and then it is a bit late. And of course it's emergency then, and they have to attend the emergency units in the hospital.
Now you talk about something as, you refer to it as inverse care law. Forgive me, is that a recognised term, or is that your own terminology?
No, that's a recognised term.
Can you explain what it means and how it affects the population you're talking about?
Yeah, I was reading a quote in the Bible once after having come across that. The first time I came across the inverse care law was during the cough visit. When the cough came into action, all practices were visited, and the doctor who came to talk to me, he said, have you heard about the inverse care law? I said, not really. So then I pursued it. Apparently, inverse care law is even in the Bible, where they say people who got plenty, they get more. People who are poor, they are given less according to the Bible. But then this is applied again in the National Health Service. In the very affluent areas, people are given better services. In the non-affluent areas like Southall, people do not get the services what they are having in the other areas, the picture is changing now, because things are coming to community primary care, and patient participation is taking place, and people are coming out to give their voices, and hopefully this should change. It is the inverse care law. Southall people have been very much denied, deprived, despite of their diversity.
And are you saying then that the reconfigurations, the out-of-hospital services, will they benefit the population in Southall?
Please repeat your question again.
Okay. Shaping a Healthier Future says it's going to cut acute services and increase primary care services and out-of-hospital services.
Well, yeah.
My question is, I suppose, will that benefit the population or not?
It's not going to benefit overnight. There's a living example we have got in Sweden. It had the highest mortality rate in the world, and it took them 25 years to address that. Today Sweden has got Sweden has got the lowest mortality rate. It will take 25 years for this area to have a lot of health promotion, preventative medicine conducted in the community, with the primary care services now being magnified, but it won't happen overnight. We need 25 years to change the structure, the system in the primary care, which has just come into the primary care, and once we have achieved that, like Finland and Switzerland and Sweden, then maybe, I won't say yes, it may be we will do as well. Not immediately.
Is it then safe or unsafe to cut emergency services before those improved out-of-hospital services are in place?
Very much so, very much so. Needless to say, it's so obvious.
So, safe or unsafe?
Pardon?
Safe or unsafe? Is it unsafe or safe to cut those?
Unsafe, very unsafe. It's deadly, devastating for the population. It's happening every day, and if you cut it, it gets worse. Already the lifespan in Southall, people live 10 to 15 years shorter. Mortality rate is high, morbidity is high, and if these services are cut, it will only multiply that. And that will again reflect on the quality of the community, it will reflect on the National Health Service funding, and already the overloaded GPs working 14 hours a day. People don't like to work in Southall. Why? Because the workload is so much.
So can I take it then, have I got this right, that what you're saying is that the deprived constituencies are bearing a greater impact through these reforms than those who live in more affluent areas? It's having more impact on deprived areas than affluent ones, is that correct?
It's very much correct, because when you are educated, like I am an Asian, I understand everything, I know how to conduct, how to seek advice, but the community doesn't. They are not. The next generation are better off, and so on and so forth. But the migration is taking place, the circulation is happening there, so there's not going to be an end to it, that the new generation is there. No, there are older people who will always be like that, and the cycle has to be repeated.
Can I ask you about the implementation and commissioning of the out-of-hospital services? First of all, does your GP practice have any involvement with the local CCG?
We do not have it direct involvement, though we attend the meetings where we are supposed to attend regularly, and I do participate with them. My son is a GP in the practice, and we got about 5 other doctors, salaried GP, and we attend these meetings regularly, but we don't have a direct involvement because the workload in the practice is so great that I give priority to my patients than to attending the meetings and following the procedure.
Are GPs in your area consulted about decisions made by the CCG? If you don't know, say.
No, can you repeat it? Are GPs in your area?
Are they consulted by the CCG about the steps and decisions that the CCG takes?
I think nationally, though the structure is there, it is not very different from when the PCT days were there. They just haven't got the time that people have come to ask them individually and what their contribution is. The meetings are there, which I used to be on the PCG group in the 7 doctors who were there. I was a woman among the 6 men. And what I noticed was they organize things and they plan things and they call a meeting and they say, we are doing this, this, this. But that's not consultation. Consultation is when you go into the depth of the problem and see what the advantages, what the disadvantages of our decisions are. I don't agree with many of them, and many GPs do not agree. Those who are participating, they talk like the people from the Northwest London team talk. but we don't talk that. We talk from the ground level and we talk for the patient that we are serving. So it's not always consulted the way ideally it should be or the way it is dictated to. No. I do have a lot of confrontations when I go to these meetings. I say no. But now I'm so pleased that the patient participation group is coming up and I'm encouraging people. I give talk in public gatherings and I say, don't sit down, go and participate in the patient participation group. Your vote is important. You can either bring it, make it or break it.
In your view then, does the CCG in your area have the backing of the body of GPs or not?
Not 100%, no. GPs like me do not support that.
And do you think you're the minority or the majority?
I think we are 50-50 really. People who are, more oriented only with the services and with, the structure, they may be 50%. But listening to the votes for Ealing Hospital closure, I think majority are against it.
I wanted to ask you about the maternity unit at Ealing, please. Can you help us with your view about the planned closure of that unit?
Right. About the maternity, we recently had a forum where they invited one of the CCG GPs, CCG leads, and I said, why have you invited him? What is he going to do for you? But then when the forum was conducted, I understood that the people were so angry, and it came out that Ealing maternity unit had got the highest number of births, 5,800 or something. And the question they put was, it is doing so well, it is self-earning, and why are you closing it? There is a population that it is serving, which is 16 to 59 years, and these people are working 22%, whereas nationally the working population during that joint service strategic needs assessment was 22 for the local population and 11 nationally. When they are earning the money, they are working, they are paying for their services, they need maternity care, they need children care, they need elderly care, and why are you shutting it down? And there was no answer. He was very embarrassed and then he just went away. And now I understand that there is a decision taken that until elections take place, the maternity unit will not be touched, which I'm grateful to and hope it continues not to be touched. And we had a person in the forum. He said, I've had 4 children and my 4 children delivered in Ealing Hospital. They had first class service and I see no reason why it should close. It is self-supporting, it is not a burden on anybody, and there's no good reason for this hospital to close.
Thank you. I have no further questions, but if you'd wait there may be questions from the commissioners.
Thank you.
Yes, thank you very much. I just have a question arising out of what you said. You indicated how overloaded your GP practice is, such that in fact you don't even manage to get to some of the meetings. So would it be right to say that in your case, the idea that your practice might be able to take up the slack, as it were, in other words, help with out-of-hospital care, is not something in which you're readily available to participate? Is that right or wrong?
Yes, it'll be very difficult because we are already overloaded. 14 hours a day working, 7 days a week. And as you know, they usually say, we don't know how tall our children are, we know how long our children are because we leave them sleeping in the bed and we come back, they are sleeping in the bed. And when that kind of a situation, you are working 14 hours a day, what is left for you to do any extra work? You have to have resources if you want services to come into the community. There has to be a balance. And at the moment, though the GPs are looking after the community and trying to improve their life, what is their own life? It's not a happy one.
Is that a picture that describes other GP practices you're aware of?
Beg your pardon?
Is what you've described applicable to other GP practices that you're aware of in your vicinity?
Most of them. I can't see anybody who is happy about it because the workload is there. I did attend a conference once, sometimes about 2 years ago, and the first agenda was GP burnout. It is a national issue. It is a problem where a lot of people are facing it because the resources are not there and the services are being pumped out from the secondary care into the primary care. Well, fine, we are happy. You give us a structure where we can employ more nurses, we can employ more doctors, we can employ more health educators, as appropriate for the community. And when they're coming into the primary care, we would love to take over the load, provided we got the system to tackle it. Otherwise, it's inhuman that you should overload it, and you are dealing with human lives. You need certain hours of rest, certain hours of upgrading your education to provide better services, but all that is disturbed.
Thank you.
You've very well described the amount of work and some of the excellent services you've developed in the area, and obviously that's a lot of expertise. CCGs, clinical commissioning groups, are supposed to be led by GPs, but it clearly is not you, and it's clearly not other GPs in your similar situation. Do you see any evidence that they've taken any note of the situation in Southall affecting patients like yours in drawing up the plans? Is there somebody they've spoken to who's given them the idea that maybe closing Ealing Hospital is a good idea?
I haven't crossed anybody saying that closing Ealing Hospital is a good idea, because it will always have an overflow from the primary care for people to attend the Ealing Hospital. I think in the next 25 years I can't see it unless they improve the services and the standard of the healthy lifestyle in the community improves, and then it could change, but I do not see it as yet because it hasn't even started. We SHIP are struggling to do it. We are not very much smiled upon. We are frowned upon. Why are you doing this? But I'm doing this because it's just in me that I will serve my community to the best of my ability. If you can't do it, I shall try and do. We collect volunteers, we give them training, and we deal with the problem, but I do not see this happening.
But it's, I just wonder if you have some impression. Clearly these ideas do not come from Southall and from Ealing, in fact. So where do you think the ideas have come from about the idea that maybe you could get better services somehow by closing Ealing Hospital and relocating services elsewhere?
The panel who conducted the Northwest London panel, they attended the scrutiny panel meeting, and I was there at the time. And the panel that was composed of members who had no idea whatsoever what was happening in Southall. And they were talking about Finland. And I said, why are you talking about Finland? How can you compare the two? I said, Finland, what's happened in Finland? I read about the Finland issue as well. 25 years ago, they used to have the highest mortality, but they worked towards it. And 25 years, they conducted the health promotion, lifestyle changes, 25 years nationally. And today, they got the lowest death rate. But I told them, I said, you don't even know what's happening. You're talking about maternity units, deliveries being conducted at home. How can you conduct a delivery at home when the family is living in one rented room? You got the father there, you got the children there, 3-4 children there, and they rented only one room. They can't afford even to rent 2 rooms. And how can you conduct deliveries there? I told them then, I said, it's nothing but criminal justice for you to say that maternity should close and they should conduct deliveries at home. It applies in the area where people are living in their lovely houses, where they can have a separate room for all the services to be conducted for home deliveries, and likewise for other areas as well. But here we don't have that comfort and convenience, which we should have. It will be a blessing.
So, would you say, can you offer an explanation as to why the chair of Ealing CCG has continued to support these proposals, regardless of obviously the level of criticism that exists among colleagues in Southall in particular?
Well, we know what politics is. Politics is supporting people without logic. You got to have, I'm a very ground level GP, I'm very realistic, and I see not my side as a GP. When I see a patient, as I tell my staff, don't look at them from your point, put yourself in their shoes and see how they feel. If you were in their shoes and you were brought up like that, you were given those conditions, you will be no better than what they are. These people in the Northwest London team, they are not supporting the community from the ground level, they are supporting the top people there, and that is called politics. That's why I never joined politics. It's not a good game to my taste, though politics have to be there, but again, it's not my way of tackling the problem. I don't join politics, no.
Thank you. I'm just curious about something. I'm retired. Sorry. You're still in practice, Doc, and I'm chickened out, I'm afraid. I'm retired from going practice. But I'm still on the Hounslow mailing list.
Sorry, can you speak a bit louder, please?
Sure. Can you hear me now? Yeah. I'm a retired GP, and I'm still on the Hounslow mailing list. I'm just curious about a letter I got to see if you got it as well, which is, in fact, it was an email. And it was addressed to the Feltham locality, and it's from Sue Jeffers, who's the NHS Hounslow CCG Managing Director. And she says that she thanks the Feltham locality directors for meeting me on the 9th of February regarding the contract and implementation arrangement for delivery of out-of-hospital services for patients within Feltham. I'm looking forward to working with you as one of the 5 new providers for the out-of-hospital services in Hounslow. And this letter refers to a meeting in February the 9th. It's an email delivered on the 26th of March. And they want to, it says, please can you confirm receipt of the above information as a provider out-of-hours services by Friday the 27th of March, and then will you be able to sign arrangements by Monday? Now, then following it comes a letter for another email dated also 26th of March from the local medical committee from, you might know, Eleanor Scott of the local medical committee, who says, goes through a whole series of reasons, 1, 2, 3, 4, 5, 6, 7 bullet points, why the GPs who are running this Feltham should not sign. One of the reasons is that training can possibly take place to enable safe delivery of the individual contracts, the specifications have not been agreed, there's unreasonable time. Now the reason I'm floating across you now is, firstly, did you see this letter in your NHS emails? And secondly, are you familiar with other instances of GPs being asked to sign documents with only, I suppose, the equivalent of overnight consideration, while still trying to run a 14-hour day?
Well, it's very obvious that GP's input is not there. And it's not the first time this kind of a situation has arisen. It happens many times, and GPs do protest against it. And I don't see how that can be conducted from top to bottom. It should be from bottom to top. And it's not right, because recently I attended a meeting in Hounslow. Of course, I live in Hounslow. I serve the community in the London Borough of Ealing. So somehow I happened to attend this meeting, which was related to diabetes. And there was a nurse who did the presentation. She said, I spoke to 20 patients. She's a Spanish lady. She speaks English. I saw 20 patients. Out of them, only 5 could speak English. And they also mentioned in the agenda that the care in Hounslow was in the bottom 25% in the national audit. So when the standard of care is that down, how can you say that GP should sign these contracts with a short notice when they're coming home? Have they got the brains to read it? Have they got the time to read it? Have they got the time to apply and assess the correct decision on that? It's very unfair. And that's why a lot of people don't want to do medicine now. I was talking to some specialists yesterday, and I said, I got 2 sons who are doing medicine. One is in the secondary care, one is in the primary care. I said, both of them, they're not happy with what they're doing, with the workload they have. And I said, I don't see my grandchildren should be doing any medicine at all, because it's not that attractive now, because when your own quality of life is gone the way it has, and I don't see. But it takes me back to the day when I was a medical student. We had a doctor, a husband and wife, who were head of departments, and they had a son. So I said, well, is he going to be a doctor? She said, no. My child will never get near medicine, because it's such hard work. On top of the hard work, when you have to work 14 hours a day, it makes it harder. And there is no solution to that. It's just bringing the quality down, though they are trying the best to keep it high.
Thank you. Thank you very